Cape Town, so it may be better to be at home in bed, sort of logging on online, than sitting here in the auditorium where it still is rather chilly. But hopefully we'll have an excellent set of lectures today. Yesterday was really good, so I welcome you today on behalf of myself and my co-chair, Dr. David Masuku, who's an honorary consultant in the Division of Pulmonology here, although he is working up country at the moment. Just remind you that those of you logging on to fill in the CPD chat form on the chat, which will appear at some stage, so that your points can be registered. Okay, well, it's now 9 o'clock and we can probably start. I'm told that Professor Salim Abdool Karim is online and ready to go. So we'll start with the first presentation. Professor Salim Abdool Karim is a very eminent scientist, epidemiologist and public health medicine specialist. He's working from the Nelson Mandela School of Medicine at UKZN. And although his first incarnation was as a very eminent HIV scientist, working for Caprisa, doing a large amount of very excellent work there, over the last 2.5 years, he has been working in the field of SARS-CoV-2. And I can't think of a better person who's going to address the topic of the fifth wave and beyond, which hopefully will be a little bit of crystal ball gazing. Professor, we're looking very much forward to your presentation.
Very good morning to all of you. It's a great pleasure to be with you. Although I have to say, I could think of a better starting time than 9 in the morning on a Sunday. But it's an honor for me to be here with you. So Kitten asked me to talk about COVID and where we are going in terms of this pandemic, and to give you just some notion about some of the challenges. Now, I see you have a talk on long COVID coming, so I won't go into long COVID in too much of detail. I'll just touch on some of those issues, but I'll focus on, in terms of this talk, I will cover, to start with, I hope I'll convince you by the end of this talk that COVID-19 is much, much more than an acute respiratory infection. And even though it's called SARS, after the original SARS was called SARS because of its respiratory impact, that this indeed is much, much more. I'll talk about the benefits of vaccines, and then I'm going to go into the main topic that I have to cover, which is what's next? What can we expect next? And I'll end off with some lessons that we've learned from COVID-19 so far. So let's go directly into it. When we look at COVID-19, we now have a much better idea. When you think about, this time 2 years ago, in 2020, we were still grappling with what is this disease? How is it causing all of these various symptoms? And why is it presenting in this way? Well, now we have a much better understanding. And I've borrowed this picture from nature, which conveys very aptly that COVID-19 literally affects the human body from head to toe. And whether we, talking about stroke or whatever we are talking about in terms of its vascular impact, that we see in almost all organ systems that are impacted. And of course, we know that that impact is not merely in the period of infectiousness. It's not merely in those first 2 weeks, but there are the long-term sequelae. And this was one of the early papers to describe long COVID. In fact, long COVID still doesn't even have a clear definition. But in this analysis, which was of about 3,700 patients from various countries, they looked at 8 months and 12 months after infection. And they found that between 10 and 20% of patients had at least some symptoms. And fatigue, malaise, memory. In fact, they describe it, as you probably are seeing in your own clinics, as brain fog. But it's not just about long COVID. And so long COVID, as we understand it, has a milieu of features that revolve around the malaise and the brain fog. But there are a range of long-term sequelae, and those are becoming apparent with time. We could not have known this even a year ago because we didn't have the data on follow-up that went beyond 12 months. So in this analysis, which compared 153,000 COVID-19 patients with 5 million historic and current controls, what they show is that there's significant long-term cardiovascular effects of COVID-19. And that principally, it manifests as greater than 50% increase in risk of heart disease. And the three key outcomes in terms of heart disease were stroke, heart attacks, and myocarditis 1 year later. And what was important in the study was not just that they saw this increase in cardiovascular disease, but that they saw it regardless of what the initial presentation of COVID was. In other words, it didn't matter whether you had asymptomatic COVID or mild or severe COVID-19 in your acute phase. And what was also important is that they showed that this increased risk of cardiovascular disease was regardless of pre-existing cardiac risk factors, regardless of cholesterol, weight, smoking, and so on. Now that was quite striking, that you see this impact across the board. It's not merely adding to existing risk factors, it's an independent risk factor for cardiac disease. And then this paper, published in the Lancet from the same group, showed something else that was interesting. Now, you all know that insulin is produced in the beta cells in the pancreas. When the beta cells have very substantial ACE2 receptors on their cell surfaces. And so the virus targets the beta cells if there's dissemination of the viral infection. So when there's disseminated infection, you will see that the beta cells in the pancreas are also impacted. Well, it manifests in terms of one of the long-term sequelae of COVID-19 as an increased risk of diabetes and an increased risk of the use of anti-hyperglycemics. Now, this is quite significant that you see this kind of impact, and this increased risk of diabetes is worse in patients with severe disease. In other words, those were more likely to have had disseminated infection. So we're now seeing you've got an increased risk of cardiovascular outcomes, you've got an increased risk of diabetes. Well, it turns out in a different study done in the UK. Now, the UK has a long-term follow-up of several thousand individuals that they are looking for the impacts of aging. And in these individuals, every 6 months, they have a brain scan. And in this particular study, they looked at about 400 patients who had acquired COVID in between their two brain scans, in between those 6 months. And in those particular individuals, most of them didn't know they got infected. They were infected asymptomatically. None had been hospitalized. Some of them had mild symptoms and knew they had COVID, but most of them didn't. So this is about 400 patients with mild or asymptomatic infection. They compared it in an age-matched control group with 384 individuals who didn't have COVID in between the two scans that were done 6 months apart. What did they find? And when I first saw this, I was struck, because what they found was those individuals who had SARS-CoV-2 infection had a smaller brain size. They had loss of gray matter thickness between 0.5% and 2%. I mean, I just thought about it, that you get COVID and your brain gets smaller. Now, it's not just that they found this, because as part of the study, they also have a cognitive function set of assessments. And what they found was individuals who had COVID compared to those who didn't have COVID, they were less able to complete complex tasks. So there's a cognitive manifestation of the impact of viral infection in the brain. So it gives you just some sense that what we are dealing with in this infection, besides the acute illness that we are most concerned about, that patients will get into hospital and that they would get into ICU and they would die, are these long-term sequelae that we are likely to see in the next several years. So let me get on to what I would like to capture as the 5 benefits of COVID-19 vaccines. Now, 4 of them are individual benefits. These are benefits that accrue to the individual who is vaccinated. And those benefits have been described in various clinical trials, and I'll summarize them here. I won't give you all of the data. I'll just give you just some illustrative data to make the point that the 4 benefits are that COVID-19 vaccines decrease the incidence of asymptomatic infections. Now, that's very important, because initially when the first set of studies were done, they focused on symptomatic disease. So I was concerned that even though you were not getting symptomatic disease, that all the vaccines were doing was converting those into asymptomatic infections. Well, it turns out that that's not the case, because even asymptomatic infections are decreased by vaccines. The second is that it decreases clinically apparent infections, and that we know quite well. All of the studies that have been done have targeted clinically apparent infections as their primary outcome. And then, of course, it decreases severe disease. And with decreasing severe disease, decreases hospitalizations and deaths. And then finally, there's some very early evidence. There are now 3 studies that show that vaccines have some impact on progression to long COVID, but it's still very early days to draw any firm conclusions. So besides these 4 individual benefits, there's also a community benefit, a secondary benefit. And this is in the fact that people who are vaccinated have a lower secondary attack rate. And so they infect their close contacts to a much lesser extent. And all of these benefits vary. They vary by the type of vaccine. They vary by the time since you took your last vaccine. They vary by the variant that's in circulation. And they vary based on the level of immunosuppression. So let me just provide you just a quick synopsis of some of the data. So if we look at the initial Pfizer trial, which included South Africa as one of the sites, 2 doses of the Pfizer vaccine decreased asymptomatic infections by 66%. So you're only now seeing 1/3 as many asymptomatic infections in those who are vaccinated. And of course, we know the initial results of the Pfizer-BioNTech trial that showed 95% reduction in clinically mild infections. But we can see how that has varied depending on the variant, just to give you some idea of the impact of variant. So the same vaccine that was 95% effective in the original trial against the D614G variant that was in transmission in the US and elsewhere, against the beta variant, the 2 doses of Pfizer-BioNTech were less effective, now down to 75%. So they lost about 20% of that efficacy just with the change in the variant. With the Delta variant, 2 doses of Pfizer tended to do better at about 88% protection. But when you get to Omicron, there we see a very different picture. If you were recently vaccinated with 2 doses and you got your last dose of your second Pfizer vaccine within the last month, we saw protection at around 67%. But if you had been vaccinated a while ago, up to 6 months, there's virtually no protection against Omicron. It's one of the reasons why Omicron has just spread so widely and impacted so many people, because there's so little protection, even if you were vaccinated, a while ago. And this is against asymptomatic and mild clinical disease. And what we see is that if you take a third dose, you take a booster, the protection against Omicron goes up. And that's what led to the widespread recommendation that you should take a third dose of the vaccine. And this relates to the level, the concentration of the circulating antibodies available. With Omicron, you need pretty high levels of circulating antibody. But we've seen across the board that it doesn't matter which variant we're talking about, doesn't matter which vaccine we're talking about, doesn't matter when you were vaccinated. These vaccines tend to do pretty well against severe COVID, hospitalization, and death. And I'll just provide you here with the New York State data, because it's one of the big studies with 8.8 million people, showing that it doesn't matter which of the vaccines you take, protection against severe disease is pretty good. And we know that from our own studies here in South Africa, that it reduces severity, hospitalization, and deaths. Now, if we look at this very early data that came from Israel, they showed here that in patients who'd been vaccinated, that they had lower levels of persistent long COVID symptoms. But this is very early, so I don't want to make too much of it, just presenting it here for completeness. But here's where the real power of vaccines is evident, and that's in its indirect effect. Here, I'm going to quote you and present you 2 studies. The first was from Science. In this study, which was really brilliantly designed, they took families in which both parents were vaccinated, and they took families where both parents were not vaccinated. And they looked at the secondary attack rate in their unvaccinated children. And what they showed is that, firstly, parents who were vaccinated had a lower risk of breakthrough infection. But when they did get infected, because we know the vaccines are not 100% protective, when vaccinated parents did get infected, that they had a much lower chance of spreading the virus to their children in their households by 72%. There's a 72% reduction in the secondary attack rate to unvaccinated children. And these are, of course, children who they are in very close contact with. So it was really a superbly designed study to look at the impact of the secondary benefits of vaccines. And then this study, published in the NEJM, looked at about 146,000 contacts of patients who had tested positive by PCR. And what they showed is that those individuals who'd received 2 doses of the Pfizer vaccine, they reduced the risk of infecting their contacts by 68%. Now that's quite significant, because in this study, they looked at individuals who lived with the contacts, the contacts who lived with the infected individual, contacts who just visited the home, or contacts who they interacted with informally, like at the pub, and then individuals who were contacts in the workplace or in an educational setting like a university. So now what this is telling us is that if you were vaccinated, that you would have a lower risk of infecting others. And that means that the benefit of the vaccines is not only to you, but it benefits the community as well. And it's important because we do want to try and reduce breakthrough infections. And the reason we want to do that, and this is a paper that just came out last week in Nature Medicine, and here, what they did was they looked at individuals who were vaccinated, and they looked at breakthrough infections in these individuals. And this was an analysis, again, similarly, it compared about 140,000 individuals to about, no, actually, in this study, it was about 47,000 individuals who had breakthrough infection to about 5 million controls. And what they show here is that even if you're vaccinated and you get infected, that you run the risk of, you have an increased risk of all of these cardiovascular outcomes and all of these pulmonary diseases. And that was quite striking for me because I thought that vaccines would provide a bigger benefit against these outcomes. But what we're finding is that even if you have a breakthrough during when you've been vaccinated, so even though there's some benefits of vaccination in terms of long COVID, we're still seeing increased risks. And of course, reinfection. So this is not just about people who got infected when they were vaccinated, but this group also showed that if you had one infection, they've already shown that you have an increased risk of all of these negative outcomes in the long term. If you have two infections, that risk goes up. And if you have 3 or more infections, that risk goes up even further. So this is quite, it's giving us a whole new perspective about us understanding that we're not only dealing with the acute problem, we're not only dealing with the infections as we are seeing them in the acute form, we've got to think about the long-term sequelae as well. So what's next in COVID-19? Well, I was asked in August of 2021 what was going to happen. And I did this interview with Bloomberg, with a journalist by the name of Pranisha Naidu, and she pestered me. She wanted to know, is there going to be a fourth wave? And eventually I relented and I said, yes, there's going to be a fourth wave in all likelihood. And she said, when is it going to happen? And I think she might have been planning some kind of function or wedding or something, but she wanted to know. So I let her know that I thought it was going to be on the 2nd of December. And there's no fancy mathematical modeling here. It's just based on a pretty consistent interwave interval. So if you just add 94 days, you pretty much get when the next wave is going to start. And of course, what happened was exactly on the 2nd of December, South Africa passed the threshold for the fourth wave, and it was declared with the Omicron variant on the 2nd of December. So much so that social media went crazy. I must be spreading this virus. How else could I know that it was on the 2nd of December? It even led to Newsweek fact-checking this. So I got asked by the minister in February of this year when we were likely to see the 5th wave. And again, just taking the same calculation, nothing amazing about it, just high school arithmetic, and it comes to the 8th of May. It turned out that the 5th wave, due to BA4 and BA5, was much smaller than what I thought it would be, and it started on the 7th of May. So we've now had the 4th wave start on the 2nd of December, the 5th wave start on the 7th of May, and basically, if you just take the same calculation again, the 6th wave is anticipated to be around the 2nd of September. Now, I don't know if there's going to be a 6th wave. It all depends on whether there's a new variant or a new subvariant of the Omicron. We are already seeing new subvariants. BA6 has now just emerged. And of course, we're seeing subvariants of BA2 that are also spreading around the world. So if you want to know, are we going to have a 6th wave? If history is anything to go by, and if the biology of this virus is anything to go by, yes, we're very likely to see a 6th wave, and we're likely to see it early in September. So what do we do? So I'm a big supporter of that we should not be living with this virus, because to me, that's very passive. That's just saying, you know, I'm just going to try and survive this virus. I don't believe that. And I don't think that's how we should be tackling this disease. I believe instead, we should be living smartly with this virus. So we live with it, but we live smartly with it. That means we have to be active in how we think about our risk. And there are 5 things I basically consider. The first is, you know, be fully vaccinated. Just make sure you've taken at least 3 doses of the vaccine. And now the data show quite clearly that, you know, when you take the 4th dose, it boosts antibody levels, but not any higher than what we already know to be achieved by 3 doses. So it's questionable whether the 4th dose gives you any specific benefit. Probably helps the elderly and the immunosuppressed substantially, but it's unclear whether it'll help others. But take at least 3 doses. Know the level of community transmission. Are the cases rising? Because you adjust your risk appetite accordingly. So I was just invited to a wedding yesterday, and I went to the wedding because I said it's low transmission. We only have a sprinkling of cases. It's very unlikely that anyone in the venue is going to be infected. So it's pretty safe to go. The chance of getting infected is very small. I would not do that if cases were rising. I would adjust my risk appetite accordingly. I would also want to know what my risky situations are and not enter into those. I would not want to enter into a room that's enclosed with no windows, windows that are closed with hundreds of people. That's just not a good idea because you're just increasing your risk of infection. And of course, I avoid distant travel if I can, not only because I want to avoid the airplanes in a high risk situation, but in low transmission, I don't have any hesitation on getting onto a flight. And I make sure that wherever I'm going, I'm confident that the health services are going to be good enough. And then finally, I think we need to be doing whatever we can to protect others, not just ourselves, but to be thinking about particularly masking in particular environments, because masking not only protects you, the importance of masking, as we know, is to protect others as well. So let me end off with, for me, a key lesson that I've learned from almost 35 years of HIV research. What can I take forward into COVID-19? And that lesson for me was the importance of mutual interdependence and shared responsibility. That if you think individualistically, you can't deal with a pandemic like this. And let me quote from the UNAIDS document entitled How AIDS Changed Everything. And I'll just take a short quote from there, where it said, and I quote, "The AIDS movement demonstrates that with a shared vision, shared responsibility, and through global solidarity, we can change the course of history." And we have. I mean, we can now make antiretrovirals available in the most remote village in Africa. We can do that because wealthy countries, in the form of the Global Fund and PEPFAR and UNITAID, they made those resources available to support. It wasn't just money, it was about support to individual countries that didn't have the resources to build up that infrastructure to provide that care. So it's that global solidarity. It's about accepting that every infection of HIV that is prevented, that infection is one that means that there's one less infection in the world. Now, I recently said that, you know, we should try and prevent every infection. And I did so in the context of preventing reinfection. So I said we should try and prevent, even if you've been infected once, don't think, you know, I can go out and get reinfected. And that got misinterpreted, that I'm talking about eradication of COVID-19. Of course, you can't, because COVID-19 is not eradicable. It infects animals as well. So, but having the shared responsibility, it's about reducing your risk, but also helping others reduce their risk. Because after all, no one is safe until everyone is safe. And this is a cliche that started very early in the pandemic, and it's as true today as it was at that time. On that note, it's a great pleasure to talk to you on a Sunday morning. I hope it was helpful. Thank you.
Thank you so much, Professor Karim. That was a very insightful talk. Any questions from my colleagues?
Thanks, Professor. Are we likely to get sort of like the influenza, a different vaccine every year? Is that what's possible for COVID as well?
Should I answer it now, or you want me to take a few questions?
No, I think we must answer. Just if you can
Okay.
answer. Yeah.
Okay, that's very good. So I don't think that we are going to go down the road of a new vaccine in every season for two reasons. One is that by the time we make a vaccine to the circulating variant and try and get it out, that new variant is gone. If you think, for example, that the Delta variant, from the time it started to the time it ended, when it was overtaken by Omicron, was about 6 months. So when you want to talk about trying to make the Delta variant vaccine, it's almost impossible, because by the time you actually make the vaccine, show that it's efficacious, and even if it's an animal studies, takes at least 3 months. And this is talking mRNA, where you can make a new vaccine fast. So by the time you get to that point, and then you manufacture, then you have to distribute. By the time you actually give the first Delta variant vaccine, you'll be dealing with Omicron. So it's actually a bit pointless. The second is that what we actually need is not a vaccine against circulating strains. What we need is a variant-proof vaccine. We need a vaccine that is not going to now be found wanting because there's a new variant. And I actually didn't put my slide up on that, but there are now at least 9 groups working on that. 3 of them are in clinical trials. And they're really smart ideas. But probably the smartest of them is what is called a pan-coronavirus vaccine. They took all of the beta coronaviruses that infect humans, and they looked at what are the conserved epitopes. What is the part of the virus that the virus can't mutate? Because if it mutates that, it can't survive. So they looked for those epitopes, and they put them all together and strung them together. So this is now a vaccine that targets conserved epitopes. Now, will that work? I don't know. I hope so. But it's a pretty good idea, because if it's conserved, then even whatever the next variant is, it will have that conserved part. Now, HIV is in the same boat, right? HIV mutates all the time, but it's highly conserved. When you think about the CD4 region, it can't change the CD4 region. Change the CD4 region can't infect humans. So this is a wily virus. Let me tell you, I mean, coming from 35 years of HIV research, and HIV is a really clever virus, and remember, these viruses have no brain, so it's not like I'm telling you real that it's clever. But this virus' ability to mutate and to string together mutations in this way is absolutely amazing. But we've got to show that we're smarter. And I'm pretty convinced that in this battle of humans versus the virus, I'm betting we'll win.
Thank you, Prof. Anybody else?
David, hi, it's Kirtan here. There's a question in the chat group as well. Hey?
Okay, go for it.
Thank you for the talk, Prof. I was just wondering, from a sort of practical point of view, I used to have quite a robust discussion with patients, talking about the benefits of vaccine. but I've lost a little bit of steam now that everyone sort of assumes that there's such high seropositivity in South Africa anyway. And my vaccine hesitant patients are still vaccine hesitant, and I don't have any more bullets to sort of give them. Do we still need to advocate for vaccines? I mean, I do try, but is there anything else we can sort of convince people that it's still worthwhile, even though everyone's assumed that they've been exposed already?
So that's a good point, because I've heard some people say we've got population immunity. We don't need to worry about this. Firstly, that's just nonsense, right? Because there's no such thing as population immunity against a variant that hasn't yet come into existence. So you might have immunity against a variant that's already in circulation, but you have no population immunity against a variant that doesn't yet exist. What you have, and that looks like it's, if it holds based on past history, that the T-cell immunity will likely protect against severe disease in future variants. But if history is anything to go by, that natural infection will not protect against the next set of variants. So that means that individuals who've had natural infection are likely to get infected over and over and over. Now, in vaccines, you have a similar problem, but it's to a lesser extent. But what's really valuable is, and this is data, I didn't put it in my slide set, but there's terrific data from a paper in the NEJM, and I would be very happy to send it to the organizers, or you can just search for it. But there's an article in the NEJM that took several thousand individuals who had natural infection, and they compared those individuals against whom there was natural infection plus a vaccine. And what they showed is that individuals who've been vaccinated, despite having past infection, they do much better against reinfection. And that's because of something called hybrid immunity, that individuals with past infection who get vaccinated, they develop hybrid immunity, which produces antibodies that are almost 100-fold higher, 2 logs higher. So they have much better protection. So anybody who comes to me and said, I don't need to worry, I've been infected, I said, you got to worry. You got to seriously worry. And if you want to know how much you should worry, look at that graph that I showed about 1 infection, 2 infections, 3 or more infections. If you're not convinced that you should be worried, then just have a look at that graph, because it points it out. And now look at the NEJM graph, which I'm not showing you. It's a Kaplan-Meier that shows that individuals who are naturally infected and had vaccines do much better. Now, to me, that evidence is so compelling that everybody who's had natural infection needs to get vaccinated. The good thing is they only need 1 dose, because the second dose of vaccine in those who have had past infection doesn't add that much value. But so at least 1 dose. They should probably take the 2 doses, but at least 1 dose. So I hope that gives you, some excitement to convince them, take a vaccine. I should just make one other point, which is with natural infection, antibodies deteriorate quite fast. With vaccination, they deteriorate much slower. So you do have longevity on your side, although that's not really much of a difference. So I hope that's helpful to you.
Prof, thank you so much. I think we're running out of time. We really appreciate the talk. Very insightful, Prof. Thank you so much.
Great pleasure.
Great. The next speaker needs no introduction. A very good friend of mine, one of my favorite colleagues in the department. His name is Dr. Ali Ismail. He's a specialist physician and a pulmonologist with an extensive research experience from Prof. Dida's office lab. It's my pleasure to introduce him, Jim. His talk is very interesting. He's going to be talking to us about long COVID. Thank you so much.
Sorry, is there a pointer? David, you're my favorite colleague too. Okay, thank you very much. Thanks for this opportunity to speak at the conference today. So my topic is very much following what Salim presented on long COVID. So this entity of long COVID has lots of names, and we know it by long COVID, long haulers. The WHO gives it a name of post-COVID-19 condition, but the name that I like is post-acute sequelae of SARS-CoV-2 infection. And essentially what this means is it refers to either new, continuing, or recurring symptoms that occur 4 or more weeks after the initial infections with COVID-19. Now, we're still not clear about the definition. So you can imagine that how can you research a condition when you can't even define it well? Some entities are saying that we shouldn't use 4 weeks because it's too short. We should use 12 weeks when the syndrome has evolved a little bit more. But essentially, I want you to not think about this as one entity. This is a diverse group of entities. You can have it in people who are previously well, who get COVID-19 with or without lung fibrosis, people with previously existing lung disease who now get COVID-19 and the lung disease becomes worse, or people who get mild to moderate or even asymptomatic infection, who initially beat the infection quite well and now have new recurring symptoms that have come up that are causing a problem. And the idea is this, that once you get infected with SARS-CoV-2, so you can see on the left there on the graph, you get this viral load that increases and your PCR becomes positive. But as you go further down the line, your PCR gets negative and the viral load gets negative, although there's a contentious that in severe disease, the viral load may stay positive for many days and months. But essentially, you can see that on the cartoon that's on the right, I can't point here, but the cartoon on the right there, it shows you that the ACE receptors, as we heard from the previous talk, are there in many organs. So it's not surprising why people actually get long COVID, because these organs are infected. And one of the things is the pancreas, as you can see there, the incidence of diabetes in people who get COVID-19 is quite worrying. Essentially, what I will do for this part of my talk is that I will ask a question that I want answers to myself. I'll pose the question and I will try and answer them. I feel that way, at least you can get answers to the key questions that you want. So the first question, how common is PASC, post-acute sequelae of SARS-CoV-2? The problem here is that if I give you a quick answer, if you look at the circle in the middle of that figure on the left, it's 2 to 91%, very wide range. And the problem here is that the studies have different patients. The time point at which you measure these symptoms are different. There's different biases, whether these patients were either hospitalized or non-hospitalized, so severity of the patients. And then the cohorts, some are big, some are small. And if you look at that graph on the right, it actually plots prevalence of this long COVID symptoms and the length of time. And as you see, that the prevalence ranges anywhere from 10% to 90%, so very wide range. But what I want to point out is that you can see those two studies. What it shows is that as time goes on, these symptoms get better. So that's one thing that you can take home. It's very wide. And the best estimate I can give you about how common the symptoms are and the prevalence of the symptoms is between 73 and 18%. So between 18 and 73% using the very large studies, if you measure it at 2 months. And the other thing here is to take home that symptoms do get better with time, and the number of symptoms as well. Now, why does it occur? Here, the pathophysiology is not clear. These are all hypothesis generating things. And essentially in the figure 1 there, it shows that the lungs get infected with the virus. Sometimes the virus gets cleared, sometimes the virus is there. There is a direct cytotoxic effect of the virus, but essentially it's the immune system that gets activated. And this immune system causes activation of your blood clotting systems and also your collagen and fibronectin systems, essentially leading to endothelial dysfunction, fibroblast production, fibrosis. So that's what happens in the lungs. Number two at the bottom is what happens in the heart. So in the heart, there are similar effects. You can have a direct cytotoxic effect, but you can have effects on the myocytes. You get myositis. But not only that, you actually get effects on the autonomic nervous system and the nerves that are supplying the heart. And essentially, one of the common features, as you'll see later on, is palpitations. And this is the autonomic dysregulations that happens. In fact, there's a syndrome that's described, which is called postural tachycardia syndrome. And that's essentially this symptom. The third one is actually what happens in the brain. Again, similarly, inflammatory markers are upregulated, damage to neurons, and that all causes blood clots in the large and the small vessels, causing dysfunctions, brain fog, and those kind of symptoms. And finally, the main and the central feature where a symptom that is generally reported by all studies is fatigue, and that's inflammation, direct cytotoxic effect of the virus in the muscles, in the brain, and in the nerves coming together to cause this very ill-defined syndrome. So two things: direct effect, damage to the tissues, and inflammatory things that emanate from that. Now, another question: does PASC-like syndrome occur with other coronaviruses and influenza? The answer is yes. If you look at the evidence from SARS and MERS, you can see that psychiatric and comorbidities with chronic fatigue, up to 4 years later, you can pick them up. Depressive symptoms, 18 months later in MERS. Impairment of lung function after SARS, very common at 2 years. And bone and radiological complications in both studies, evident up to 15 years later. So this entity of long COVID and long symptoms is not something new to the SARS-CoV-2 that we're seeing. We've seen this before. But what about influenza? So this very nice study, it actually took a cohort of 270,000 patients, and it was during the time that they were recruiting for COVID-19. These were influenza cases that occurred as well simultaneously during the same time period. And the propensity matched the patients with severity and to make sure that comorbidities, level of severity of disease, etc., to make sure that there was no confounders. And essentially, well, to reduce the number of confounders. And essentially what you see, figure A and C is a group of patients that we're looking at between so essentially 1 month to 6 months. And the B is only looking at the second part of the definition, which is basically from 3 months to 6 months. And what you see is that patients with COVID-19 had a higher occurrence of this long COVID symptoms compared to people who are suffering from influenza at the same time. And if you look at the core symptoms, the 9 core symptoms in the spider graph at the bottom, it is statistically significant that patients who suffered from COVID-19 had a higher odds ratio of having these symptoms persisting. And similarly, even if you look at the late onset symptoms, basically symptoms beginning 3 months after the initial infections, the same holds true, that patients with COVID-19 were more likely to get long COVID. Although long COVID can happen with influenza, it was more likely with COVID-19. So another question, this is a common question that I get asked. Is post-COVID infection with Omicron any different from Delta infection? And this is interesting. This is a recent publication in the Lancet. And what you're seeing there is the odds ratio at the bottom. And what they're showing is that no matter when you get vaccinated, if your vaccine is more than 6 months, between 3 and 6 months, or less than 3 months ago, the chances of so Omicron cases were less likely to experience long COVID. How less likely? 4.5% less likely. Sorry, it's about 50% less likely. It's 4.5 in the Omicron group versus 10.8 in the Delta group. However, remember that long COVID cases in the UK, so this is data from the UK, actually increased from 1.3 to 1.7 million cases. And this was just a numbers game. It's because although it is less likely for Omicron sufferers to actually go on to the long COVID syndrome, the numbers are just too huge. I mean, you can imagine that if you're having 350,000 new cases every single day at the peak of the wave, you can imagine that 4.5% of that is quite high already. So what are the commonest risk factors for long COVID or for PASC? So I decided to look at it using 3 large studies. As I said, that studies are very heterogeneous. But what you can see here is a story. Females, firstly, and there is a theory behind why females it's to do with some hormonal and more autoimmune phenotype but it's still under research. So females, firstly, increasing age and the elderly is the second risk factor that's common across the group. Severe COVID-19 infections and people who actually get hospitalized for them, and asthma. There are others, high BMI, existing mental disease, but essentially your phenotype is an elderly woman with comorbidities who is hospitalized, is essentially the people who will actually get this long COVID. Now, what are the symptoms? There are lots, and you can see in that graph, lots. The bigger the circle, the more common those symptoms are. So if you see there, fatigue and headache that catch your eyes. So those are one of the commonest symptoms. But essentially, I think it's easier to group these symptoms into 3 groups. So you can put it as cardiorespiratory. So when you're sitting in your practice, it's easier to think about this. Cardiorespiratory, neuropsychiatric, and others. So cardiorespiratory is essentially the shortness of breath and the fatigue syndrome together with palpitations. And the neuropsychiatry is all the psychiatric disorders together with anxiety, headache, memory lapses, brain fog. And then there are non-specific symptoms such as fatigue, which is one of the commonest symptoms, and loss of taste and smell, which is also very common. And what is interesting is that the figure on the right, the heat map on the right, actually shows you the white whisker plot actually shows you when these symptoms start. And you can see at the beginning of your disease or at the beginning of your first month of starting the post-COVID, you've got respiratory symptoms more commonly. But as you move down, you can see the time frame at the bottom is that the respiratory symptoms actually become and mold into non-respiratory symptoms. And they can persist, or they can be completely new symptoms that you never had before. And these are new symptoms that actually evolve. And this is a graph that shows it very well. So you see the symptoms on the left there are symptoms on admission. And on the right are symptoms that continue to persist. And you can see that some symptoms that you started with, for example, dyspnea, fatigue, fever, cough, can carry on. But there are some very new symptoms that start. So for example, confusion, problems with sleeping, dizziness, swollen ankles, they all come up a bit later down the line, which weren't there before. So that's how the symptoms change over time. Another question, are children at risk of long COVID? And the answer is yes, but it seems like they are to a lesser extent. At what proportion? You saw the figures for the prevalence for adults, and it was very variable, but certainly in kids, it seems like it's anywhere between 0 and 13%. And the symptoms are similar. If you look at the heat map on the side, the redder the bar, the more common the symptoms are. And you can see the same things coming up: fatigue, headache, insomnia, fever. So these are the kind of things that the kids explain. So children do get it, less extent. And there is some data to suggest that these symptoms may resolve quicker than in adults. So another question here, I think that needs to be addressed is that COVID, severe COVID and COVID ARDS, is it different from ARDS due to other conditions? And the reason I'm asking this question is that I want to know that if you get severe COVID and COVID ARDS, your chances of getting PASC, would that be different from somebody who had different ARDS, like a non-COVID ARDS? And the answer to this is that there's no difference in the outcomes of patients with COVID ARDS versus ARDS due to any other condition, for example, other infections. In fact, basically, these patients who actually get ARDS and are admitted to the ICU, a large proportion of them get fibrotic disease, very similar to the non-COVID ARDS as well. So fibrosis is very common. You can see ICU admission 14% versus just about 14. So that's statistically significant. Essentially, what I'm trying to show this is that these are 3 different types of patients: non-hospitalized, hospitalized, and ICU. And you can see that in the ICU group, the symptoms when you measure it at 6 months, they've got brighter colors there, which means that those symptoms are more prevalent in people who are who've come to ICU. But this is generally both for COVID and for non-COVID ARDS. So essentially, there is no real difference between COVID ARDS, especially if they've got fibrotic lung disease, and their progression and their clinical resolution is similar to the non-COVID ARDS group. This is data from Nev, who's going to present this at the SETS conference. But what I want to just point out is this is data from E16. Essentially, most of our patients who've been to ICU have got a decreased DLCO, which is at 60%. They've got bilateral disease, and the commonest symptoms is shortness of breath. And these are the patients that you have to give time. That's what's required here. Those with fibrotic lung disease need time. So the question comes in that I've shown you that post-COVID-like syndrome is seen in viral diseases that are such as influenza. We can see them. But do we see them in other infections? So for example, before the pandemic, there's a clear link of anyone coming to the ICU. Essentially, ICU-acquired weakness is very common. Cognitive dysfunctions in patients who have been in ICU, 30 to 80%. And even in post-sepsis syndrome, essentially, people who get hospitalized for any infection, you can clearly see that a lot of them have persisting symptoms. And these are roughly the trajectory. You come to the hospital, either you get better, back to your normal self, or you never really get back to your normal self and you remain with persistent impairment. So this is not something new that we have seen, but COVID-19 has just, this is at a scale that's been very unprecedented. And this is an interesting finding. So the question that I asked here is that, do all patients with dyspnea have fibrotic lung disease? So you'll see a lot of patients, and dyspnea is quite a common presentation. Many come with fatigue, and fatigue can sometimes be confused with dyspnea. But essentially, this is a graph of exercise pulmonary testing. A is actually people who have a normal response. So what I'm plotting there is for A, on the left is breathing frequency and minute ventilation, and on the right, the green graphs are tidal volume and minute ventilation. And as you can see that as tidal volume increases, the minute ventilation increases. A is normal. B is a person who's had respiratory insufficiency and is stopping due to respiratory problems. So the tidal volume doesn't increase as well with minute ventilation, and they actually stop because of respiratory reason. And finally, the third one is actually people who have dysfunctional breathing. Dysfunctional breathing simply means that your pattern of breathing is disrupted. And you can see that they're all over the place. They don't track nicely very well. And this study showed this. I want to highlight three things in this study. The first one is that if you compare respiratory limitations from fibrotic type lung disease, for example, compared to dysfunctional breathing, people with dysfunctional breathing will have a more clear chest X-ray, less fibrosis on the lung, and that can be seen with the DLCO, which is near normal, which is the last block at the bottom there. You can see the DLCO is about 85% in people who have dysfunctional breathing. These people are less likely to have gone to ICU. So they might have milder disease of dysfunctional breathing. And finally, they may be younger. So what I want to present to you is that not everybody who comes complaining of not being able to breathe and tiredness may not have fibrotic lung disease and could be this entity of dysfunctional breathing. In fact, this is a patient that Dr. Rain shared with me yesterday. It's a 44-year-old lady with severe COVID-19, hospitalized and treated with steroids. Highest oxygen support was high flow nasal oxygen, non-smoker, no cardiac or respiratory disease. Lung functions were near normal. And this was her chest X-ray. And you can see the chest X-ray doesn't really have those fibrotic ARDS scars that we normally see. And this is Dr. Rain's, he's the expert at this field, but you can see that when we subjected her to pulmonary exercise testing, her reason for shortness of breath was actually suggestive of deconditioning. And there was also some ventilatory pattern abnormality. As you can see that there was a rapid shallow breathing throughout the exercise test. So it is important to take home that dysfunctional breathing can be perceived by the patients as dyspnea. So not all people complaining of dyspnea would have fibrotic lung disease. Okay, I've shown you this once again, and I just want to touch on that part. One of the risk factors for long COVID is increased age. But the question that we're now asking is that, is long COVID only associated with patients who had severe disease and older age? The answer is no. So if you look at this study in about 247 isolated patients, done at 6 months, you can see that the prevalence of any symptoms of long COVID at 6 months was about 50% in a very young group. And in fact, I just saw this preprint, which is not peer reviewed. Essentially, the highest risk factor for who gets long COVID was actually asymptomatic infection. Now, this is not peer reviewed, and it's been since March. It's been hanging in that area, so not to take on. But asymptomatic patients can also get long COVID, so don't forget about that. Finally, vaccination, can it affect the risk of long COVID? I think we saw this in the last slide, and this actually just confirms that. It's a very small study, but essentially shows that if you've had 2 doses of your vaccination, this was done during the beta delta phase, it shows that you've got less likely chance of getting into long COVID. How long does the symptoms last? The symptoms lasts a long time. It can last up to 6 months, probably longer. But the issue here is that symptoms do get better. If you just analyze presence of symptoms at 6 months, they will be present, but most of the patients, I would say 90% of the patients, would have some improvement in their symptoms. Essentially, what can you do about long COVID and how should you deal with it in your practice? So this is just a summary. First, you confirm that the patient has COVID. Remember that the proof that this patient suffered from COVID-19 is not required. Secondly, identify what cluster this patient is presenting with. Is it the 3 things? Is it the cardiopulmonary? Is it the neuropsychiatric? Or is it the other symptoms? And focus that which of these symptoms is the most bothersome to the patient and address that. Important thing here is to exclude other diagnoses. I mean, it's very easy to write off things to COVID when there's active depression, for example. So always keep scores, like simple scores, the depression scores and the anxiety scores, which are very important. Rationalize medication. Here in the public hospital, we very commonly slap people on all sorts of drugs. When they're in ICU, we use haloperidol and they sort of get carried on at home. Rationalize the medications that the patients are on and make sure that is this the medications that are needed. Antihypertensives I've seen is a big problem because they get postural hypertension. And it's very easy to mistake these with palpitations and dizziness, which actually comes with it. So rationalize medication. You do a basic evaluation. Extensive investigation in patients who do not have any reasons for that is not required. You can do a mini mental blood pressure, and postural drops is also very important. And feel free to refer to a specialist. And the patients that you want to refer are patients who have developed new symptoms or very dangerous symptoms suggestive of some dangerous conditions. When do you see the patients? You start seeing them at 1 month. That's the recommendation, and schedule a follow-up with them depending on the severity. Investigate persistent symptoms. If the symptoms are persistent up until 3 months, I think those are some things that warrant investigations. And I get this question a lot, again, about the role of vitamin, coenzyme Q, and probiotics. Coenzyme Q, because the fatigue is quite commonly as chronic fatigue syndrome that we see. And this has shown to help somewhat with that. So I'll show you a study. This is a very small study. They took 2 groups of people, gave vitamins to one and multivitamins to one and no multivitamins to other. Multivitamins were vitamin B, C, Ds at high doses, and then they gave some olive oil extract that has been shown, like lots of other B vitamins by B6, B12, and a concoction of that. And essentially, this is a very small study, 20 patients, so 10 positive, 10 negative, and a control group. And essentially what this showed is that there was improvement in energy, tiredness, tension, and calmness. So in my view, I feel that if it's not a financial burden for patients and the risk of harm is less, give it. Vitamin D for post-COVID, only give it if there is deficiency. If you suspect that there's deficiency, then give it. And lastly, with time and support, a lot of the symptoms will improve. So finally, just in conclusion, PASC is a very big group of people. So one solution will not fix everything. And any people with any severity can actually get it. just importantly, a nurse-led or a GP-led system can work very well for PASC, and selected benefit from specialist referral when required. So I'll end here. Thank you very much.
Thank you. Thank you very much, Dr. Ismail. I'll take one or two questions. Vince at the back.
Thank you. Thank you, Dr. Ali. That was an excellent presentation. Really appreciate that. I just have one question. On one of the slides, there were 2 of the 3 studies that you mentioned that just showed us the most important risk factors. And I saw on 2 of them, asthma was one of the risk factors that came out as being a risk of developing PASC. Is there a link between the risk factor and the type of symptom syndrome that is eventually developed as part of the PASC group?
Yeah, so that's a good question, Quincy. The problem with those very large studies is that it's very difficult to tease out a single risk factor. So this is something that comes up as positive for the group. I'm not sure if patients with a pre-existing history of asthma actually develop dysfunctional breathing, because we know that's common. But I'll answer that question in a different way. So if you look at the cardiopulmonary exercise testing study that I showed, one of the things that they controlled for was asthma in that one. So essentially, asthma was equally distributed across this group, and dysfunctional breathing did occur in all those groups. But I can't answer your question directly. I'm not sure if having asthma would either predispose you to cardiorespiratory versus neuropsychiatric or versus other. I'm not sure of that.
Dr. Ali, if I can ask one more question as well. In Johannesburg, I see a lot of colleagues, specialists, especially pulmonologists, giving our patients oral anticoagulation, especially Xareltos and Pradaxas and all that for patients with so-called PASC syndrome. What's your take on it?
So they have looked at these things. At the moment, medical therapy with PASCs, unless if there's a strong indication for giving that atrial fibrillation or other, it is not required. In fact, it can harm. So oral anticoagulation routinely for patients with PASC is not recommended.
I'll take one more question.
In rheumatology, the rheumatologists use like amitriptyline for fibromyalgia. It improves quality of sleep and it helps fatigue in that way, plus the pain. Does any role for amitriptyline for PASC?
Yeah, thanks, Dr. Vali. So essentially, the trial for amitriptyline is actually ongoing. I think that it is reasonable to in the persisters. So basically, if the symptoms of chronic fatigue is persisting and you feel that there is depression, or it's worthwhile using these kind of treatment that, for example, work for other diseases. But amitriptyline itself, at this point in time, has no role in post-COVID lung disease.
One last question online. The role of biomarkers in the diagnosis of a PASC.
So this is an interesting question, because they have looked at multiple biomarkers, and the common ones are CRP, D-dimers, and a couple others. But essentially, what the problem that we're facing is that at the moment, the study that actually is going to answer this question definitively is ongoing at the moment, and it'll report maybe in the next 3 or 6 months. But the point here is that having a positive biomarker, which we don't know what it means, is something that I would definitely take seriously and investigate. So if a CRP is continuously high or the D-dimer is continuously high, this is something that would prompt me to investigate this patient a bit further. But to make a diagnosis based on this biomarker, at least initially and in the first phases of post-COVID, is not required.
Thank you so much, Dr. Ismail. That was a fantastic presentation. We're going to move to the next speaker. The next speaker is Dr. Crystal Arnold. She's got a background of neurosurgery, newly qualified critical care specialist, worked in our ICU at Critical Care. She's going to be talking to us about the COVID-19 in ICU. Thank you so much.
Good morning, everybody. My name is Christelle. Thank you very much for the opportunity to speak to you here this morning. And I'm going to be chatting to you this morning about COVID-19 in the ICU. Was it worth the effort? So my disclosures, apart from the fact that I'm a neurosurgeon at a pulmonology update meeting, we're all good. Looking at the question COVID-19 in the ICU, is it worth the effort? I can't really state the answer better than Dr. Zeus. Sometimes a complicated question has a simple answer. Why such a complicated question, you ask? Many factors, in my opinion, contributes to the complexity of this question, including triaging, trying to cope in a reactive healthcare system, the COVID-19 pandemic presenting itself as a new disease needing to be studied with unknown variables, debate on treatment modalities, including colchicine, ivermectin, dual anticoagulation, biologicals, and a rush for vaccine development. The impact on elective surgical services, the impact on other medical services, including the shutdown of outpatient department clinic visits, specialist clinic visits, access to healthcare services in general, and the access to medications during lockdowns. The post-pandemic impact, and as our previous speakers have so nicely illustrated, how we're going to cope and deal with picking up the pieces after the pandemic impact, as well as the emotions that came with the COVID-19 pandemic that hit us, and fear, anger, frustration, and anxiety being only a few of the emotions experienced during this pandemic. I would like to share some of our ICU response at Grootersdorp Hospital during the COVID-19 pandemic and how we went about it. So our pre-pandemic ICU service at Grootersdorp mainly consisted out of 25 ICU beds, did not include the neurosurgery ICU beds on this platform, as the neurosurgery service was mainly unaffected and just needed to move to make space for isolation ICU to be continuous during the pandemic time. We're all very familiar with these images. This is our COVID-19 national dashboard as depicted basically during the first 5 waves. And very clearly you can see that not only in our national dashboard, but also in our provincial dashboard, our wave 2 and our wave 3, I think, was the most severe throughout the country, with ICU admissions reflecting this pattern as well. Utilization of ICU beds and the expansion of the ICU service at Grootersdorp Hospital was fluent during the pandemic, and bed spaces were adjusted according to COVID bed needs, as well as the non-COVID ICU service. This was more or less how the platform expanded during the first wave, with the total ICU bed capacity running at 60 beds and peak admissions hitting 12 admissions a day. The majority of wave 1 we ran 44 ICU COVID beds and 16 non-COVID. During the progression of the pandemic during wave 2, we did start feeling more pressure on our non-COVID service, and our split during the wave 2 pandemic was an equal 50-50 split, with 30 COVID beds and 30 non-COVID beds, and peak admissions dropping down to about 8 admissions per day. During the third wave, we, in a functional matter, lost 2 of our ICU beds that was just reintegrated back into the cardiothoracic service. So we were down to 58 beds, with peak admissions down to 7, and COVID service still running 30 beds with non-COVID service at 28 beds. And then finally, during our 4th wave, we managed to retract down our ICU bed capacity down to 39 beds, which is still roughly about 8 beds over our total ICU platform capacity. But as you can appreciate here, our COVID service was only running approximately 6 beds during the 4th wave, with our non-COVID service coming under heavy pressure and running 33 beds for the non-COVID service. The COVID ICU admissions had dropped to 1 admission roughly every 4.5 days. So definitely the pressure was off by the 4th wave in our service. As I had mentioned very briefly before, the neurosurgery service was managed to maintain throughout the 3 waves. In terms of the ICU bed capacity, they just had to move location. The cardiothoracic elective lists stopped, especially during the first 3 waves. So there were some of these beds available on the non-COVID ICU platform that we could utilize and support the non-COVID ICU service. And most of our incidental COVID-19 patients that were admitted came from trauma, cardiothoracics, neurosurgery, and general surgery. And I would like to very briefly just share with you some of our ICU outcome data that we published in SAMJ this year. Basically what we did is we just wanted to describe the clinical characteristics, course, and outcomes of our ICU patients that we admitted with COVID-19 ARDS to the ICU, and these only included patients that were intubated with an endotracheal tube and required invasive mechanical ventilation respiratory support. And just to update those that don't know, that Groote is a 991-bed public sector tertiary level teaching hospital that's affiliated to UCT. And we basically did the study in a prospective manner. It was single center cohort, and we looked at all patients with lab confirmed SARS-CoV-2 pneumonia, as well as ARDS criteria, who were intubated, receiving invasive mechanical ventilation. This is essentially our experience during the first 12 months of the pandemic, from the 5th of April 2020 to the 5th of April 2021. And these basically captured the first 2 waves of the COVID-19 pandemic. Our results, this is our console diagram. So in total, we had 461 patients admitted during those first 12 months. 32 patients were excluded based on their SARS-CoV-2 PCR tests that were either inconclusive. Another diagnosis was made for 3 patients. They were actually diagnosed with new diagnosis of TB. There was also a patient diagnosed with RSV, which we ended up with 429 patients with COVID PCR positive, and then a further 49 patients that were excluded because they did not fulfill the ARDS criteria. So we ended up with 380 patients with COVID ARDS for our first 2 pandemic waves, essentially. The demographics in terms of our 380 patients, essentially we had a very equal split in terms of male to female ratio, so a 50-50 split. Median age of 51, which is young in comparison to international literature, which is probably a function of our triaging tool that was quite stringent in terms of how we triaged our patients. You can also appreciate here that the majority of our patients had comorbidities. We had 10% of our patients with HIV infection, and you can also appreciate here that the BMI shows that more than 2/3 of, or nearly 2/3 of our patients actually were obese. And then just as a summary, looking at clinical and lab characteristics of patients that we admitted with severe COVID-19 ARDS, we had a mortality of 69.2%. This is hospital mortality. And again, as you can appreciate here, that our survivors were slightly younger than our non-survivors, with 48 years of age compared to 53. Our non-survivors had also a longer symptom onset to ICU admission, 10 days compared to 8 days. And this was actually found to be statistically significant, although clinically not really very useful. But we did start to notice the trend in terms of our referrals. And our ICU length of stay was much longer for our survivors, which was 19.5 days, in comparison with our non-survivors, which was only 7 days. This is difficult to compare to international literature. We had a much longer length of stay for our ICU survivors. We don't have, as a lot of the international facilities or centers have, access to weaning or step-down facilities for invasive respiratory weaning ventilation. And then just looking at the last little bit of the table, you can also appreciate here that the vast majority of our patients had high flow nasal oxygen pre-ICU admission. And looking at the SOFA score and the PF ratios, you will see that they were much lower in the non-survivors compared to the survivors. And again, in terms of vasopressor support for patients were more commonly seen in non-survivors compared to survivors, as well as the renal replacement therapy. We offered VV ECMO to 6 patients. We had 3 survivors and 3 non-survivors, and tracheostomies were placed more commonly in survivors versus non-survivors. Looking at the univariate and multivariate analysis, maybe I'll just touch on the multivariate model. The 3 associations with mortality and severe ARDS ended up being age, admission SOFA, and male gender. We were more likely to have an increased mortality. And looking at by comparison how we fared in the compared to international communities, looking at ICU mortality and ARDS mortality internationally, the first column actually depicts our own results. So as you can appreciate here, we've got quite a large cohort of patients in comparison. These studies that I included here were some of the earliest studies that came out looking at epidemiological data for ICU COVID-19 ARDS mortality outcomes. It was very difficult to try and do comparisons as definitions were not uniform at that stage. Different definitions were applied to the term of invasive mechanical ventilation or mechanical respiratory support. Different modalities were used in terms of how mortality was expressed, and not all of the studies actually looked at things as like comorbidities, SOFA scores, and PF ratios. But I tried my very best looking at all of these data to try and get all these data points to compare. So as you can appreciate here again, we've got a large cohort at our center in comparison to some of the earliest studies published. Our population was younger at the age of 51, as I mentioned previously, probably due to triaging quite hard. And a little bit different to what we saw in international studies, we actually had a slight female predominance in our population, whereas most of the international literature reported a male predominance. We had the majority of our patients with at least one comorbidity. And as you can appreciate here as well, our BMI in our population was quite higher than in comparison. Our SOFA scores are actually a bit lower in comparison, but just to note that we actually did not score our CNS SOFA for these patients, as the vast majority of our patients that were admitted with COVID-19 ARDS was actually sedated and paralyzed, and therefore we didn't actually score them for CNS. And our PF ratio, I think, is an interesting point maybe to highlight, that we actually had the lowest PF ratio in comparison to these studies that I've shown here. So whether or not we actually admitted our patient a little bit too late, or tried to push on with high flow a little bit longer, or maybe the fact that our patients were maybe just a little bit sicker. But as you can appreciate, our PF ratio actually in comparison was quite a bit lower. And as I mentioned before, ICU length of stay quite long, 19.5 days. And our mortality, again, as you can appreciate here, much higher than comparison to these studies mentioned here. So how we came through the waves. So this is a very brief snapshot of the progression of our waves. You can see our wave 1 being our longest wave, lasting 34 weeks, and where we actually had the majority of our admissions of 309 patients. Our hospital survival at that point was 35.3%, with wave 2 having not about half of the patients, with hospital survival again very similar. Our wave 3, we had a dip in our hospital survival. It's maybe also important to mention that this is also a wave where we experienced an outbreak of a carbapenem-resistant Acinetobacter, and that this may have very well impacted on our hospital survival. And wave 4, which was a very small blip in comparison to our first 3 waves, were mainly incidental patients, referrals from trauma, neurosurgery, cardiothoracic surgery, and acute care surgery. So you will see that nearly 100%, all but one patient, were all incidentals, and all of them not actually having a diagnosis of COVID-19 ARDS. So the conclusion to the study was basically that patients with COVID-19 ARDS who required invasive mechanical ventilation and admission to a tertiary ICU to our center during the first 2 waves had a hospital survivor of 30.8%, and survivors had a median length of ICU stay of 19.5 days. The SARS-CoV-2 infected patients with severe acute hypoxemic respiratory failure require prolonged invasive mechanical ventilation, leading to high resource utilization. And in our setting, even though we used very strict triage criteria, we were unable to identify any clinically useful prognostic factors in patients that we admitted for invasive mechanical ventilation. Interpretation of critical care patient outcomes during a pandemic that overwhelms healthcare systems is challenging. Larger standardized data sets may help shed light on strategies to improve patient selection and outcome. Crucial would be uniformity in defining the context in which critical care was delivered, including the use of invasive mechanical ventilation and the reporting of standardized ICU and hospital outcomes. Many things, I think, came out of the COVID-19 pandemic, and maybe to kick us off before I start with the formal pros and cons list is the major input from research collaboration and all the research opportunities that came through this pandemic and how quickly we responded. So this was one of the papers that came out of Groote Hospital depicting exactly the organizational response of a hospital critical care service that was published in the SHACC. This is the paper that I very quickly, briefly shared some of the results with you that was published in SAMJ this year. This was a brilliant paper that was published by Prof. Caligaro and his group in Lancet eClinical Medicine on the utility of high-flow nasal oxygen for severe COVID-19 pneumonia. Another paper that was actually based on an MED from an anesthetic registrar that was published in Thrombosis Journal, looking at the evolution of clot strength in critically ill COVID-19 patients. And then, of course, the very famous ACOS study paper that was published in Lancet last year, an absolute brilliant paper, and really just looking at all these research opportunities and outputs. Other pros that I think came out of the COVID-19 pandemic not only included the massive amount of teamwork that came through, but also the new skills that we acquired, prone ventilation, re-emphasis on lung protective ventilation strategies, as well as the utilization of newer technologies like electrical impedance tomography, cross-departmental collaboration, not only in a research capacity, but as well as the clinical arena, with lots of support for the critical care departments. The research collaboration not only locally but also internationally that laid future infrastructure for ongoing research efforts. The massive sense of pride and responsiveness to the pandemic and the fact that we could toe the line and step up, overcoming our fears, and many other lessons learned. This is arguably the first pandemic in the era of social media boom and everything that had come with it and we had to deal with, as well as the efficient use of telemedicine and teleconferencing, allowing us to communicate with our colleagues overseas and learning from each other. Some of the cons that we definitely experienced during and will still be experiencing after this pandemic does not only include the healthcare costs, and we all know that a national state of disaster was declared by our president during this pandemic, but also the direct and indirect economic costs of jobs lost, and that'll have a massive economic impact for many years to come. The difficulty in triaging, especially for clinicians that were not used to doing it. I'm thinking here more of countries that had more resources and have not had to do triaging as hard as we've been used to in the past. The sense that there were deprioritization of elective surgery services such as surgeries and medical outpatient visits, which led to, I think, a huge amount of frustration, as well as massively strained critical care services that had to deal with the load and burden of patients that we were seeing, and healthcare worker burnout that we cannot forget, and we will probably be still dealing with this for many months to come. And all of this leading to the concept of, we're all aiming towards a healthcare system where we can be proactive and practice preventative medicine and move away from what's actually seen as sick care, where we function in a reactive healthcare system where we're always just trying to play catch up. So some of the post-pandemic solutions, and as my previous two speakers have so beautifully spoken about, Prof. Abdool Karim talking to us about the fifth wave and beyond and where we're going from here, and Dr. Ali Ismail informing us about long COVID and the tsunami after all these waves, and some of the other solutions that's being suggested, such as catch-up lists, extra OPD visits, and other solutions still to be. So when I think back about the COVID-19 pandemic and how we either swam through it, sank through it, or drowned through it, I can't help but think of the words by J.R.R. Tolkien. I wish it need not have happened in my time, said Frodo. So do I, said Gandalf, and so do all who live to see such times. But that is not for them to decide. All we have to decide is what to do with the time that is given us. So if you ask me about COVID-19 in the ICU and is it worth the effort, my answer is an absolute resounding yes. I would like to acknowledge and extend our gratitude to all our colleagues at Groote and across the nation who worked so hard to provide excellent care to our patients during this global pandemic. We also acknowledge all families that have been affected by the COVID-19 pandemic and the many, many who lost loved ones. Thank you so much for your invitation and your attention. And I would like to use the last few minutes to address any questions, if there are any.
Thank you so much. I'll take one or two questions. We need to get back. We're actually running behind on time. I'll take one or two questions, please. Any more questions? Anyone? Any questions at all? Okay, Crystal, can I ask you this one question? I see you had on your survivors, you had about 3 patients who were on ECMO and the other 3 that actually passed away. Looking back now, had you had better resources? Do you still think there was a role for ECMO in managing patients that were actually failing on conventional mechanical ventilation?
Of course, we are limited by our resources, and the patients that we chose for supporting with VV ECMO were very selected patients. And those of you that work at Groote know that there's a very strict ECMO governance group that actually goes and reviews these patients and assess, their suitability or candidacy for ECMO support. And I mean, there's a lot of data coming through the ALSO group now, sharing their experience worldwide with ECMO survivors with COVID-19. But I mean, saying that, they also have their patients actually off mechanical ventilation running ECMO. So we don't really run our ECMO circuits that way. So our patients tend to be ventilated, sedated, and also then requiring the support of ECMO. And I mean, the survivors now from the ALSO registry shows that patients with COVID ARDS receiving ECMO support, VV, the majority of them being VV configurations, are down to about between 40 and 45%. So, we're almost in that ballpark figure with our 50% survival for our ECMO survivors. It's just that we only have the use or the access to one ECMO machine at a time. There was a very brief period in, I think it was the second wave or the start of the third wave, where we overlapped, and we actually had Mackie supporting us with the second ECMO device, and we actually overlapped 2 ECMO runs for about 2 weeks. And that was quite hectic, because from a nursing point of view and staffing issues, it's very heavy in resource demand.
Any questions? In absence of questions, so we're going to move on to, we're going to have a tea break and join the next speakers at 11 o'clock. Thank you so much. Thank you, Shorta.
Thanks.